Epidemiology of knee injuries. Knee injuries account for over 50% of injuries in college and high school athletes. Two of the more common diagnosis results from physical activity are patellofemoral pain and ACL sprains, tears. Patellofemoral pain is defined as pain in the knee region that is provoked or accentuated by actions that involve motion at the patellofemoral joint and or increased pressure of patella against the femoral condyles. The ACL is one of the primary stabilizing ligaments of the knee, whose primary function is to prevent anterior displacement of the tibia relative to the femur that can result in either a partial or complete tearing of ligaments. It is also possible for secondary injuries to the medial collateral ligament, medial meniscus, and or lateral meniscus to occur simultaneously with an ACL injury. Across multiple sports, the overall incidence of ACL injuries is similar between genders. But in sports where both men and women compete, soccer, basketball, the injury rate is higher in women. Those individuals who suffer an ACL injury and undergo surgical intervention face a lengthy rehabilitation process ranging from 6 to 36 months, and only 75% of these individuals are able to return to their previous activity levels. Furthermore, individuals suffering acute knee injury, such as ACL injury, are 7 times more likely to develop knee osteoarthritis, approximately 25 years following the initial injury, as compared to those individuals with no history of acute knee injury. The development of patellofemoral pain can also be devastating due to reoccurrence of symptoms. Surgical treatment is an option for patellofemoral pain. However, little evidence exists favoring surgical interventions over conservative management. In a retrospective investigation, 91% of individuals diagnosed with PFP reported continued knee pain for 4 to 18 years post-presentation with restricted physical activity in 36% of these individuals. Common knee injuries, patellofemoral syndrome. Page 473. One of the most commonly accepted causes of PFP syndrome is normal tracking of the patella within the femoral trochlea. When the patella is not properly aligned within the femoral trochlea, the stress per unit area on the patellar cartilage increases due to a smaller contact area between the patella and trochlea. Abnormal tracking of the patella may be due to static or dynamic lower extremity malalignment, altered muscle activation of surrounding knee, decreased strength of the hip musculature, or various combinations. Malalignment of patella within the femoral trochlea is commonly associated with an excessive Q angle. The Q angle is formed by a line drawn from the anterior superior iliac spine to the central patella, and a second line drawn from the central patella through the tibia tuberosity. Holmes and Clancy described the Q angle as an attempt to measure the vector forces applied to the patella, responsible for guiding the patella within the femoral trochlea during knee flexion and extension. A large Q angle is believed to facilitate excessive lateral tracking of the patella, which may lead to ultimately to develop a PFP. The underlying causes of an excessive Q angle include patellofemoral anteversion, external tibia torsion, genuine valgum, knock-knee, and foot hyperpronation. Computer pauses. It's the NASM book on the computer that's faulty. Muscle activation of the quadriceps may also influence patella alignment and subsequent PFP. Researchers have suggested that oblique fibers of the vastus medialis must activate earlier or at the same time as the vastus lateralis because a delay in vastus medialis oblique activation may lateralize the patella, leading to suboptimal tracking, increased stress on the patellofemoral, cartilage damage, and pain. Abnormal transverse and frontal plane motions of the femur may alter patellofemoral mechanisms, causing PFP. Reported that 30 degrees, Lee et al. Reported that 30 degrees of femoral internal rotation cause a significant increase in patellofemoral joint stress. Also, femoral adduction has been proposed to cause an increase in the knee valgus angle, and in turn, lateral tracking of the patella. Weakness of the hip external rotators and adductors may allow the femur to move into excessive hip adduction and internal rotation, further increasing the lateral contact pressure of the patella on the femur. Also, femoral adduction has been proposed to cause an increase in the knee valgus angle and in turn lateral tracking of the patella. Femoral adduction has been proposed to cause an increase in knee valgus angle and in turn lateral tracking of the patella. Okay, so it has been demonstrated that people with PFP have decreased quadricep flexibility, shortened reflex time of the vastus medialis oblique, reduction in vertical jump performance, increased medial patella mobility, increased distance between the medial tibia condyles of the right and left legs, tibial bowing, and increased quadriceps strength as factors associated with the incidence of PFP, patellofemoral pain. These studies support that both static alignment and strength of the lower extremity musculature may play a role in the development of patellofemoral pain. The risk factors of PFP are thought to include increased femoral rotation, adduction, and knee valgus during functional tasks, decreased strength of the surrounding hip and knee musculature, and increased Q angle and foot pronation. Anterior cruciate ligament injuries. ACL injuries are overwhelmingly 70 to 75% non-contact in nature and almost always occurs as the body undergoes rapid deceleration. The three major non-contact events described as being responsible for ACL injury are planting and cutting. Number 2, straight knee landing, ouch. And one-step landing with hyperextended knee. Large shear forces are placed across the knee when performing these types of maneuvers and may result in high degree of ACL tear. Figure 13.15. Specific movement patterns commonly occurring during ACL and lower extremity injury include knee valgus, excessive leg rotation, and decreased knee flexion. Knee flexion angle influences ACL stress as vigorous quadricep contractions at low knee flexion angles, 0 to 30 degrees, may generate enough anterior tibial shear force to rupture the ACL. Large amounts of ACL loading occur during the combined loading state of tibial rotation and knee valgus. While the knee may appear to be in valgus, a true opening of the medial joint space is not thought to occur. This visible valgus largely comes from internal rotation of the femur at the hip. As such, lower extremity rotation, tibial and femoral and knee valgus occurring during cutting and landing maneuvers are viewed to be of sufficient magnitude to generate extreme loading across the ACL, causing spontaneous rupture of the ligament. It is during this combined loading state of excessive tibial rotation and knee valgus that researchers have described the ACL to be a greater risk of injury. Movement patterns are important and modifiable factors that may influence the risk of ACL injury. Lower extremity movement patterns play a critical role in injury mechanisms, as they are known to influence the load and deformational forces on ligaments, meniscus, cartilage, and bone. These factors are modifiable through exercise-based interventions. Thus, exercise-based injury prevention programs that successfully alter movement patterns by decreasing the visible knee valgus, minimizing tibial rotation, and increasing knee flexion angles pose the potential for reducing the incidence of knee injury during sport and recreational activities. Gender of the athlete is not a modifiable risk factor for ACL injury. Research continues to show that female athletes are at greater risk for ACL injury compared to males. Schultz conducted a review of research examining two possible explanations for this increased risk in females. A structurally weaker ligament that is more prone to injury, increased risk in females. A structurally weaker ligament that is more prone to injury, development of less knee protection, and higher relative loads on the ACL. Research supports the notion that females generally have a smaller, less stiff, and weaker ACL compared to males. Females often demonstrate landing mechanics characterized by greater extended posture, less hip and knee flexion, resulting in greater forces at shallow knee angles, as well as greater knee valgus. Along with teaching proper landing mechanics among female athletes to reduce the stress on the ACL during sport activities, improving muscular strength and coordination among the muscles crossing the knee joint may prove valuable in reducing risk of ACL injuries. Patellofemoral pain and ACL injury prevention. PFP-related exercises should focus on strengthening of the hip and surrounding knee musculature. Strengthening of hip muscles are thought to assist in decreasing hip internal rotation, adduction, and knee valgus during functional activities. The use of exercise to strengthen the quadriceps is also regularly performed, since many individuals with PFP are reported to have quadricep weakness. Most individuals with PFP respond favorably to conservative intervention, with the most common treatment being quadriceps and hip musculature strengthening. Weight-bearing exercises are more functional than not weight-bearing exercises, because the multi-joint movement requirement facilitates a more functional pattern of muscle recruitment and stimulating proprioceptors, making weight-bearing activities preferable. Proprioception balance training and plyometric agility training are the two main programs recommended for preventing ACL injury. Other common training techniques incorporated in ACL injury prevention exercise programs are technique movement awareness training, strength training, and flexibility training. A systematic exercise selection process based on the individual's movement patterns observed during assessments will provide the most effective information in determining program for PFP and ACL injury prevention. Since altered movement patterns are believed to be one of primary causes for PFP and ACL injury, selecting exercise to correct faulty movement patterns is a logical approach to preventing these injuries. Knee pain.